Assalamu alaikum. Thank you very much for the kind introduction. So I will briefly present about JAK inhibitors and the utilization or switching of JAK inhibitors in RA patients. So this is data taken from an Australian registry called the OPA registry. And interestingly, in Australia, patients with RA can basically utilize or undergo any kind of treatment that is judged by their rheumatologist to be the best treatment, so there isn't necessarily restriction on choice. So therefore, utilization of the three JAKs in that country is quite efficient, I would say. And basically, all three JAKs that are available in here were included in that study because they were the same JAKs that were available in Australia. So the main objective of that is to basically describe the switching between the JAKs and also describe the switching between JAKs to other classes and to see whether this is utilized in routine clinical care or not. So the data was collected from the OPA registry, and it included about 112 rheumatologists across Australia, and patients were eligible for enrollment if they were adult patients with RA between 2015 and 2021. And the data was utilized to describe the switching and the duration of therapy or survival. So over 55,000 patients were included, and about 12,000 and more were on biologics, and of them were 5,900 patients were on JAKs, and this included all the JAK inhibitors, all three of them. Median persistence ranged from about a bit less than 35 months for tofacitinib and a bit less than 19 months for upadacitinib, and baricitinib was in the middle between the two. However, keep in mind that tofacitinib was the oldest, about 5 years before UPA being introduced in that particular country. So 50% of all first-line switches happened from JAK inhibitors to a TNF inhibitor, and there was and afterwards, like after a first-line switch, patients were less oftenly switched to a TNF inhibitor, but rather to biologics that are non-TNF biologics. Interestingly, about 30 to 36% of the patients had JAK cycling or JAK inhibitor cycling throughout their therapy. So in later lines of therapy, switching between JAKs and TNFs was less oftenly, let's say, used or practiced among Australian rheumatologists. And interestingly, that patients were more likely to be on a CSD-MARD if they were first-line switchers or first-line users, and they would less oftenly use combination in later switches. And this is interesting, maybe because they did fail CSD-MAD, so maybe the practice is to stop it or not accumulate cost or whatever. So the most common reason for switching would unfortunately be lack of efficacy, and this is what is really known from diverse RA literature. So we look into the characteristics of patients, and we see about 500 to over 1,000 patients on JAK inhibitors, whether first, second, or even third line. And interestingly, on average, these patients had a median age of 60, and majority was, as expected, females with a duration of disease for anywhere between 1 to 7 years, and very high disease activity if they were first-line JAK users, and a bit less disease activity if they were second or third line JAK users. Now, this is the survival of the JAK inhibitors, and you can see that baricitinib and tofacitinib had somewhat comparable survival. Upadacitinib had less survival, but keep in mind it was it came quite late in that country, so this might have affected the time point of collecting data. So as first line, second, and third line use had basically very good persistence for all the JAK inhibitors, and interestingly, first-line users had even better persistence or better longer month of use compared to second and third liners. And switching patterns, basically, as we've discussed, had on average of anywhere between 1 to 4 years of follow-up, and a very good percentage of patients remained on JAK inhibitors, even if they were second or third line users of JAK inhibitors. However, about 30 to 40% also switched the treatment, and switching to a JAK inhibitor happened in about 30%, give or take. So a CS DMARD used during the switch was quite oftenly practiced, and lack of efficacy was the most common reason for switching biologics in RA. So in conclusion, in this large set of database from a registry, it shows that utilization of JAK cycling could perhaps be an effective method for controlling patients. This adds to the data that we have that cycling between JAKs might be an effective method for controlling RA, and it is a little bit different from what we know from TNF inhibitors. However, the limitation of that study is being a retrospective analysis, and this is an open source for bias, as we know. So that was my presentation. Thank you very much. This is the disclosure and funding by Eli Lilly.
Thank you, Dr. Mufaddal. So we move to the next speaker, Dr. Ibrahim Al-Maghlouth, who's a professor of medicine and rheumatology at King Saud University in Riyadh. He's a consultant rheumatologist and director of Medicine Research College at the King Saud University. And he's going to talk about the biologics in lupus, and in particular belimumab, real life or real world data. Please.
Well, thank you so much for this nice introduction. I have to disclose that I'm not yet professor, but thank you, hopefully in the near future. I'm really delighted and thankful for the organizing committee for accepting the this presentation and this work to be presented. On behalf of the authors of this paper, I would like to thank the organizing committee again. So what we're going to present today is the real-world effect of intravenous belimumab on clinical outcome of patients with systemic lupus erythematosus in Saudi Arabia. That's part of the OBSERVE study. OBSERVE study is a sponsored study on the impact that aimed to assess the impact of belimumab on the patient with lupus from Saudi Arabia. And these are the disclosures there listed as you can see. Now, I will tell you one thing before I start the introduction. I suck with presentations, so I don't like to read from presenting slides. So I'll try to go over, switch a little bit, and not to be very scientific in the way I present this, but go with the primary reason why this study was done. Primary reason why this study is done, we all know that Benlysta or belimumab is an approved medication for the treatment of lupus as an add-on therapy for both mucocutaneous and musculoskeletal disease, as well as recently for renal disease. But the primary problem that we face in clinical practice is actually, one, getting approval for the medication or accessibility of the medication in the institute, given the potential cost. And the argument is usually, even though this is a phase 3 clinical trial proven medication, still does it work in our population or not? One of and the reason being is that we know that many of the medications has racial differences. So some of the medication may not have the same response that you anticipate within a certain race. And unfortunately, the Saudi population or the Gulf region in general have not been represented in most of these phase 3 clinical trials. So from a regulator, as well as from a physician who usually deal with lupus patient, we don't really know whether this medication works in our patients. That's number one. Number two, We also select for these patients the most difficult patient to treat, people who are not responding to usual treatment. And that means that we are trying to show an efficacy in a very hard to treat patients. So that was the primary reason why this study was conducted, and I really acknowledge and thankful to the company sponsoring such activity to assess the efficacy in an independent scientific way. Now, as you know, belimumab can come in two forms, IV and subcutaneous. This study was restricted to the IV form because of the historical development of the IV first before the subcutaneous, and to ensure that the exposure, which is the treatment of belimumab, is actually assessed in the same way, we restricted the study to the IV form. So that's actually the first part of the rationale of the study. Now, the method, this is a single-arm study where a patient who been decided by the physician to have belimumab as an added-on therapy because of their refractoriness of disease were eligible to be included in this retrospective single-arm study, where the index is the first time they received the IV belimumab, and the time interval that we assess the patient is before the index, 6 months, so assess their disease activity before they receive the treatment, how they were doing, and then 6 months after to see how they were doing after the initiation of treatment. So in this particular design, this patient population serve as the exposure and the control. So they are the one who received the treatment, and they are the one who were not on treatment before. So we're comparing before and after. Now, the eligibility is very important. Two parts of eligibility: the recruitment physicians. So the physicians that were part of this study, it's a multi-centric study. The physicians were actually experienced physicians in managing lupus patients. They were required to have at least 10 patients with lupus at the time of the inclusion of study. They need to have 5 years of experience, and they had to have at least 2 or more patients treated with belimumab, and at least 1 patient with belimumab at the inclusion time of the study. Now, what about the patient population that were included? The usual inclusion is essentially patients who fulfill classification criteria of lupus, adult patient 18 and above, receiving IV belimumab. Again, that's from historical component. The studies of switching from IV to subcutaneous was reassuring that they are similar in efficacy, more or less. But because of the study time period, we restricted the exposure to the IV belimumab. In addition, the medical history of the patient was mandated to be present in order for the patient to be included, and that's essentially obvious. The exclusion criteria is those patients who received subcutaneous, patients who were enrolled in other clinical trials, and patients with severe lupus nephritis in which belimumab was used before the appearance or the presence of the phase 3 trial. And the reason why we are doing that to ensure the homogeneity of the study population. As you know, the initial approval of belimumab was for the refractory lupus without severe lupus nephritis, and that was the rationale why restricted it to that study population. The primary outcome is very important. So the primary outcome that was chosen for this study is the practical outcome that physicians usually do in this situation, which is the physician response, overall physician response, 6 months after the treatment. The reason why 6 months, because that's the average estimated time to have real efficacy assessment, although some of the efficacy of belimumab can appear 2 months from the initiation. The definition of physician response is either worse, the same, or improvement with a certain degrees or margin, low, intermediate, or high. Other outcomes are very important. It's the proportion of disease flare-up after the initiation, and that's very important for us as a clinician. I wouldn't add any further treatment if it will not minimize the number of flare-ups and the severity of the flare-ups. The changes in laboratory markers, the changes in proteinuria, and I want to highlight this as an important outcome because there is a lot of discussion on whether the use of belimumab might modify the natural history of a disease or not. So it will be worth looking at their baseline protein level and the changes, knowing that those patients are not known to have lupus nephritis in general. Okay? And of course, we want to look at the steroid-sparing effect, and that's important for acral damage, and that is a justification for added therapy to start with. So this is the results. The overall response, overall we had 4 physicians, so 4 center enrolling patients, 47 eligible patients, and 44 completed the 6 months follow-up of belimumab, and most of those patients were female, ages 33. The demographics are very similar to what you treat with lupus in general. I want to highlight a very important part, which is the moderate to severe patients at baseline are majority of the patients. So remember, those patients are severe refractory patients. Yet, and the other characteristics are listed here. Now, because of the time, I will try to skip a lot of things, but I will go back here. So this is the results at 6 months post-treatment. You can see that the clinical improvement was achieved in a significant proportion of the patients. In another way, we only had 1 patient who did not have significant improvement. The rest of the patient had improvement, most of which are actually clinically significant, i.e. they have moderate to at least severe, moderate to significantly improved, and about 20 to 40% of improvement was noticed in 8 of the patients. So the medication showed significant efficacy in patients with moderate to severe in majority of them, and that's very important. Now you can see that the pre and post response on the flare-up rate. You can see that pre-index, the flare-up rate was high, about 50% of them had flare-ups, and the proportion of flare-ups reduced significantly post-treatment, so that's the second outcome was achieved. Changes in serology, not much on the, significantly on the double-stranded DNA, and some changes on the CRP. Complements were not dramatically different. But what is more important is also the changes in the proteinuria, and that highlights the potential of this treatment to treat even subclinical disease activity. Now, I have to highlight those patients were not biopsied completely, so we don't know their stats before and after, but by all means, it was a favorable outcome. Now, most important part, and that's the last that I'm going to highlight, is the steroid-sparing effect, and that's paramount on the management of lupus patient and prevention of acral damage. You can see that there has been significant reduction of a steroid use before and after, and that persisted after the treatment. So what I want to conclude with, and this is, I think, the most important part, belimumab is a very interesting medication that has been proven on phase 3 trials on mucocutaneous and arthritis, as well as in lupus nephritis lately, to be an effective added-on therapy for lupus patients. But what is very important, we can see from this study that this medication also works in our population, and it works quite well, even when there is moderate to severe disease activity. And the steroid-sparing effect is clearly demonstrated with this study, highlighting the importance of this medication. Before I leave, you will ask a very important question. What about the comparison between this treatment and a control group that did not receive the treatment, since this is a single-arm study? And what is the cost implication of this medication if you are practicing with the mindset of health economics? And I will answer this soon in the next study. Thank you so much. I would like to thank all the authors and Dr. Saeed, who is the corresponding author of this paper. I would like to thank the company taking the courage to do a study in this population and demonstrate to assess the efficacy of this medication. I encourage all the companies to do similar things in our study population. Thank you. So I think you had enough of me, but apparently I'm presenting another paper. So I will just do a quick introduction. We are so proud of the level of work that the trainees and the future rheumatologists are doing in the field. As I mentioned, one of the very important questions that we had in mind is whether Benlysta or belimumab actually works in comparison to a control group, not only on an individual who are moderate to severe, and how is the implication of cost to regarding the utilization of this medication. So to address this question, we had the opportunity to work with a very good talent. Dr. Abdullah is a medical intern who was part of the group that conducted a very nice retrospective cohort study on the cost consequences analysis of belimumab versus standard of care. And although I'm his supervisor and I'm supposed to present, I think we all believe in the future talent. So he will do the honor of presenting, and I will be here to back him up and answer any further question. Without further ado, please, Dr. Abdullah, proceed.